My name is Miriam Yattassaye. I'm a clinical nurse in the operating room. I first came to Penn State in 2018. And when I started out in the operating room, it was really with the mindset of allowing myself to think beyond patient care at the bedside, on the floor, and really trying to expand past emotional intelligence and towards a little bit more mechanical and technical intelligence, which I think the OR is really great for that. So when I started in the operating room, one of the things I found most intriguing was our blood product waste rate in the OR. And just to give you an idea, the national waste rate for blood products is about 6%. 70% of that is thought to be in the operating room. And some sources cite 75% if you include trauma room, the trauma bay. Now, 6% doesn't seem like much, but when you think about how donations are increasing only by 3% every year while the demand is increasing, 6% could be a bit of a hefty number. These numbers were even before the pandemic. So now we're talking about people who are getting sicker and are in need of blood transfusions. But the population that's able to donate is more afraid to go out into the spaces that allow us to donate. Okay. Now, I suppose there are quite a few variables into why the blood product waste rate is so high in the operating room. And some of the literature I looked at was of clinicians who were attempting to reduce blood product waste rate throughout their entire organization. And 3 of the sources noticed that the projects they used to reduce blood products in the entire hospital were effective, except in the OR and trauma area. Like, yeah, our project works everywhere else, but something about the operating room, our ideas just aren't working out too well. I'll give you an example. One of the hospitals decided to modify the cooler that they were using to transport blood into the operating room. And they packed the cooler just a little bit differently. They had more ice packs. They had a weighted lid to make it easier to close. But they found that they didn't get as much of an improvement in the OR as they were anticipating. The authors of this particular project stated that more work needed to be done in this area. So as I was looking for solutions, I sort of dissected these particular hospitals that stated that their operating rooms and trauma bays needed a little bit more work. And I started looking around our operating room to look for clues that may sort of guide me as to why this was going on. And one of the things I noticed right away is that in like all other units and all other areas, our policies and guidelines are often written without the reality of without the reality of those particular situations in mind. So, for instance, our policy says we bring the blood product coolers to the OR trauma bay, and those coolers are monitored to make sure that they remain closed so that the blood products can remain within temperature range for use. Well, as you can see, the amount of chaos that goes on in the OR and trauma bay would make it a little difficult to remember this little cooler over here. And maybe sometimes that's left open when we're not, when there's 500 or 50 people in the room, not all at once, but at any given day, we're coming through that room. A few hands have gone back and forth between the cooler and the patient, anesthesia, blood products being delivered. The chaos of that moment does not allow for clear and consistent adherence to the policy and guidelines. Human error is going to affect how viable these products are going to remain. And imagine that the patient is in that trauma bay or in the OR for about 8 hours or so, while clinicians are attempting to stabilize the patient. Then you're looking at wastage rates. In Penn State, for instance, in 2018, I was reading our track record that we had lost about 800 units of packed red blood cells in a year. And a majority of it, actually it was more than 800 blood cells lost, but just more than 75% of it, 800 of it was in not the children's operating room, but the main operating room. So when I first approached my OR manager about this, that this was a personal concern of mine, I'll get into a little bit later about why this particular subject gets to me. But when I first approached my nurse manager about it, I said, you know, maybe one person specifically dedicated to monitoring the blood product. Not only is it viable, is it being maintained well, is it being mishandled? Should we stop the mass transfusion protocol now? Should we keep going? Do we have enough coolers? If we have one person specifically trained and responsible for that job, we might see less waste. Luckily, by the time I brought this up, our organization was already in the process of creating such a role, and our MTP coordinators right now are getting rave reviews. Our circulators in the operating room found them to be very helpful, and it's a testament to how that responsibility was an overwhelming item to add to an already full list of things to do for circulating nurse, who's trying to make sure that the patient and the surgeons and the staff members in the room have everything they need in the middle of this chaos. So when I realized we already have an MTP coordinator who is going to be responsible for blood products, I then went to the next step, which is what would this coordinator need to be successful in their role? And not only what would they need to be successful in their role, but what would we do in the event that we could not have a coordinator in the room? Let's say 2 or 3 mass transfusion protocols are going on at the same time. What does a circulator do in the event that they do not have that support? So I went again and looked at the literature, specifically at the hospitals that had tried modifying the coolers, and I focused in on the human error factor. And I decided that we needed to look at the use of different kinds of coolers, and we needed to explore modifications that would help our hospital do better. The blood bank was very helpful and very supportive in this goal. And since then, they've tried at least 2 different models of coolers from different manufacturers. And again, in the search for these coolers with the blood bank, the goal is less human interaction, hoping that it equals less error. And what we're really looking for is a self-closing cooler that maintains temperature, because in interviewing nurses, I have found that having to be responsible for keeping the cooler consistently closed, for keeping the blood products off of the shelf and inside the cooler and safe and secure was difficult to do in the midst of all these other lists of things to do that you have to prioritize at that time. Again, while talking to technicians in the blood bank and searching for a product that would meet these particular challenges, I also started daydreaming of what this cooler would look like. What kind of tools would the MTP coordinator really want in a chaotic environment? And my drawings, I would compare some to what was already on the market. I would compare some to what we have done before, what other hospitals have tried. but a majority of my calendar was interviewing other circulators, not only in our hospital system, but also at UPMC and Lancaster General. Lancaster General, I found out more details about the MTP coordinator role, as they had already started using that role for several years now. So most of the past 2 years, I started this in 2018. The past 2 years, I think, have been spent interviewing stakeholders, sort of fine-tuning the design, and writing a protocol for a possible prototype to be tested. I think the biggest barriers have been the engineering knowledge deficit. So I'm trained as a registered nurse. I do know some registered nurses who had previous degrees in engineering or accounting. Engineering background would have been really great in this particular project. However, the fact that I work at Penn State and have access to so many resources, I find it to be perhaps the most valuable resource so far while trying to work on this project. So I went and I approached my manager, who then led me to other contacts. And I think every contact that I talked to would either help provide information or lead me to another contact that would be able to get me where I needed to go. So the knowledge deficit at first seems like a barrier and would discourage most nurses from moving forward. But when you're working in a well-connected organization, you can find comfort in knowing that where you don't know, someone else's expertise begins. And that's where an interdisciplinary team can start from. So I sought out others' advice and others' help. The other barrier was perceptions of nurses as caregivers and not innovators. For that, if I approached someone about this project and the feedback I got, well, pass that on to an engineering team somewhere and they'll take care of it, or isn't that for surgeons and medical tech or medical technology companies to work on? What's a nurse doing working on this? I would always try to remind myself of other nurse innovators, one in particular who came up with the EMR, another one who came up with the crash cart. We are the ones who these technologies are going to impact the most. Nurses are the ones who are acutely aware of the challenges in healthcare. And oftentimes, when those challenges aren't managed correctly, we bear the brunt of it. We also happen to know what the possible solutions to those challenges are. So while there's been a few who are surprised at the idea of a nurse innovator, I think for the most part, after a few conversations, it makes perfect sense that nurses need to take ownership of not just our challenges, but the solutions to those challenges. And the other barrier has been the pandemic. And at first, the pandemic seemed like a barrier, and then it occurred to me that it was just enough time to sort of fine-tune the design, one. And then also, it turned out that the project I was looking at to retain blood product viability in a chaotic environment could also be applied for vaccines. So sometimes, I think in all three of those examples, we've just demonstrated that sometimes the barriers that may seem to get in your way end up being tools or assets that enhance your innovation, your solution. Okay. When I first approached my nurse manager about this, it was Mike Blum at the time and Rob Bosch, they directed me to the blood bank, and I was able to connect with Dr. Melissa George and Sean Ernoy. And I remember also Mike Blum telling me to reach out to Mary Lou Konoski in Nursing Research Department. And then Mary Lou Konoski, after working with me on the Grace Lipson Innovation Project, after I was able to get the award to support making prototype, we then got started on the Center for Medical Innovation training there that helped to fine-tune the design. The Center for Medical Innovation, Erica Swift, was really helpful in pointing me in the right direction as far as industry support. Manufacturing knowledge deficit was another barrier, but through the partners that the Center for Medical Innovation works with, I was able to sort of answer questions that would help prepare my design for production eventually. And then the Harrow Science Library, in between talking to Sean Ernoy at the blood bank and applying for the Grace Lipson Innovation Award, I must have contacted Mike and Seamus at the Harrow Science Library hundreds of times, working on a 3D print model. And then Penn State Engineering, the Penn State Engineering capstone project with students right now is really exciting. None of the knowledge deficit that I experienced in the first 2 years matters anymore as long as you have the experts working with you on the project. And I think Penn State Engineering helped to close that gap to where my nursing expertise and their engineering expertise, I think, will help make this solution successful. Okay, so currently we have several 3D models that were completed by Harrow Science Library. There's a prototype that is scheduled to be completed by engineering students in April 21st for their capstone project. And at that point, we begin testing in the blood bank. IRB application is still going through approval. It's still going through the approval process. And we anticipate a determination that says it's not for human subjects. If testing goes well or up, as scheduled by July of this year, we should know whether or not the schooler does indeed reduce the chances of human error when blood products are stored in this manner. The reason this matters to me is because when I was 7 or 8 years old, I remember being on a camping trip and malaria hit me pretty hard as a kid. By the time my parents had gotten to a rural hospital, it was at a point where I needed blood transfusion. Now, blood transfusions in a rural hospital in sub-Saharan Africa is a little tough to come by. And I still hear stories today, my mom talking about how difficult it was to get a certain blood product that they needed to save my life and how close I was to not being here. I understand that there's quite a few out there who probably have been in that position and think, wow, a pack or two and I would not be alive. So for me, the idea of there being less donations, but there being a greater need is one jarring reality that should not be amplified by any blood products being wasted. And from my point of view, if reducing waste is a matter of changing a cooler or changing a practice, that is worth countless lives. And the amount of time and effort that I spend in working on this project, in my mind, is validation for why I was able to survive that life-changing event. I want to thank you all for attending and for giving us the time to present our ideas and for being supportive and encouraging. And I want to encourage you all, whatever that idea might be that you have in the back of your mind that you wonder whether or not can be made into a useful product to help us all. I encourage you all, especially now when times are changing so drastically and so much is required of nursing and healthcare professions. I encourage you all to think beyond the role that has been so narrowly defined for nurses. It doesn't seem so narrow to us, but the rest of the world assumes that nurses were just at bedside and maybe taking orders, but I think they're going to see nurses take leadership role in adapting and helping us all navigate the next few decades of really challenging times that I think are coming. Thank you all for attending, and I appreciate your time.